we need to have a normal, healthy switch off to the parasympathetic and back and forth.
Exactly. And it wasn't
yeah.
that long ago that we were the ones running from the lion. So, I mean, it's, these are survival mechanisms that run in the background that keep us alive and keep our system going. But it gets a little bit sideways because now, although maybe most of us in the developed world aren't facing down wild beasts, there are lots of threats, unfortunately, and it is a messed up world. And whether or not it's an abusive parent or a boss that's yelling at you and you're fearing for your job, or other horrible things like mass shooting events. I mean, there's so many flavors of, 1 in 4 women have been sexually assaulted. I mean, there's so many flavors of trauma that come at you, but physiologically, they look the same to your body. And it's not, you don't have to earn your trauma. You don't have to have something really super big or be, knee deep in hand grenade pins when you're in combat. It is something that if you get triggered and that trauma becomes too much, anyone can have that trauma get stuck in the on position and it doesn't spin down, and then it becomes PTSD. Yeah, and what we do for that is this conversation comes together in the sympathetic chain going through the neck, and if we precisely inject a portion of long-acting local anesthetic around that nerve, we turn off that conversation and we kind of break the loop.
Cures, Remedies, and Beyond podcast with Dr. Irina, a Stanford-trained medical doctor, inventor, and a published author with over 30 years of clinical experience, is bringing together the science of medicine and the art of healing for ultimate vitality and health. It engages in discussions with healthcare providers, wellness experts, innovators, philosophers, spiritual and industry leaders, as well as health and wisdom seekers to provide you, the listeners, with practical tips and knowledge to help optimize your health and well-being. The Cures, Remedies, and Beyond podcast with Dr. Irina.
Welcome to the show. Our topic today is a novel treatment of anxiety and post-traumatic stress disorder with the unique treatment that is called Stellate Ganglion Block. To discuss this, we invited, in my opinion, the most qualified physician in this field, Dr. Sean Mulvaney. Thank you for joining us, Sean.
I'm glad to be here. Thank you for inviting me, Dr. Mulvaney.
You have an incredible background, Sean. For 31 years, you had a military career, serving our nation's special operations community as both a U.S. Navy SEAL officer and a U.S. Army physician. And you have a strong passion and dedication treating our active duty special operations military men and women, as well as veterans and general public. You had also become the first physician in the Department of Defense who got credentialed in minimally invasive sports medicine to treat musculoskeletal and sports injuries. And you were the first to use Stellate Ganglion Block to treat combat-related post-traumatic stress injury, as you call it. And you have published over 15 studies and research papers on this topic since 2009. That is really impressive. And I also heard some of your stories, and obviously you are the most qualified to talk about PTSD, because I remember some of your unique military experiences that you mentioned to me, not to that cause actually PTSD in me just to hear your story, when you were swimming for a few hours with the crocodiles to get to the shore with all your military equipment on you, so along. Anyway, so really privileged to have you describe, what exactly Stellate Ganglion Block is, and how did it become a treatment for PTSD?
That's kind of a mouthful there, because really the stellate ganglion, really we have to back it up to, you have your kind of conscious nervous system that you think about, what you want to do or where you want to go get coffee. But you also have a background nervous system, the autonomic nervous system, and it's running in the background all the time. You and I aren't thinking about breathing. We're not thinking about maintaining our body temperature. We're not thinking about digesting food. And if a bear were to come into the room, we wouldn't think about what to do next. We would, all of us, have the exact same response. It would happen automatically without thought. We'd stop digesting food. We'd send all that blood out to our skeletal muscles. Even our pupils would get large to see if there's more bears in the corner. These things all happen without any thought. They're survival mechanisms, and they're complicated and they're complex things, but they're not something we have conscious control over. And what we know can happen in certain situations like chronic anxiety or chronic or post-traumatic stress disorder, what can happen is that system can get stuck. It's normally designed to switch back and forth smoothly. Picture the gazelle running from the lioness on the Serengeti, and it's running away with everything it's got, and the lioness is chasing it, and then the lioness gives up the chase. The gazelle runs another 20 feet, and it goes back to grazing. It was just running for its life, literally running for its life. And now it goes back to digesting because it can't metabolically afford to stay freaked out. It can't metabolically afford to stay in that heightened fight or flight response. It's got to nourish itself for the next time. As a kid, I would watch nature shows and it'd make me nervous. Like, the lion is right there. Well, the gazelle lives on the Serengeti. The lion is always right there. And it has to be able to switch back and forth smoothly between fight or flight, rest and recover. Fight or flight is the sympathetic nervous system, and then rest and recover is more the parasympathetic nervous system. There's some crossovers there, but the bottom line is we are designed to switch smoothly between fight or flight, rest and recover. We're driving in a car. It's a dark, rainy night. We realize that we're hydroplaning and the car in front of us is stopped for some reason, and we think we might hit that car. Our entire body, whoosh, gets activated. People say that's adrenaline. It has nothing to do with adrenaline. Adrenaline would be secreted from on top of your kidneys. There's a gland, the adrenal medulla, and it would secrete a hormone, cortisol, adrenaline, catecholamine hormone.
But it's too slow.
And it would have to circulate through your body,
right,
taking about 2 minutes till you felt that. But when you have that situation where something dangerous faces you, whoosh, your whole body is activated on a cellular level as soon as that danger is recognized. And that's the autonomic nervous system, or the sympathetic nervous system in this case. And when
we actually, just to ask,
oh, sorry, go ahead.
Yeah, no, and just to ask you, we actually need that, right? So because that sends all this, network impulses, so to actually activate, our whole body for potential fight or flight, right? As you said, so meaning that we really need that sympathetic system activation, as you said, because our body works in a similar way to gazelle, as you mentioned. So because we need the increase in the heart rate, we need the muscle toning right away, right? So we need more air in our lungs, which is what is actually sympathetic nervous system governs, right? So, but you're saying that it has to be a perfect balance, it has to switch off at a certain point. Otherwise, we cannot really in a healthy way sustain ourselves. We need to have a normal, healthy switch off to the parasympathetic and back and forth.
Exactly. And it wasn't that long ago that we were the ones running from the lion. So, I mean, it's, these are survival mechanisms that run in the background that keep us alive and keep our system going. But it gets a little bit sideways because now, although maybe most of us in the developed world aren't facing down wild beasts, there are lots of threats, unfortunately, and it is a messed up world. And whether or not it's an abusive parent or a boss that's yelling at you and you're fearing for your job, or other horrible things like mass shooting events. I mean, there's so many flavors of, 1 in 4 women have been sexually assaulted. I mean, there's so many flavors of trauma that come at you, but physiologically, they look the same to your body. And it's not, you don't have to earn your trauma. You don't have to have something really super big or be, knee deep in hand grenade pins when you're in combat. It is something that if you get triggered and that trauma becomes too much, anyone can have that trauma get stuck. in the on position, and it doesn't spin down, and then it becomes PTSD. So the way that it works is that there's parts of the brain, different parts of the brain throughout the brain that control the autonomic nervous system. It's referred to by the CAN, the Central Autonomic Network. And the CAN, that part of the brain that controls these background functions, not your conscious thoughts, they speak to the body. And then the body speaks back. And they do it through the cervical sympathetic chain, or what's commonly called the stellate ganglion, but really it's the cervical sympathetic chain that it's connecting the parts of the brain that control this response. And then it connects it to the body on a cellular level, and then the body talks back to the brain. And this is
goes both from the brain to your body.
Yeah.
And then it goes, so the signals from the body actually go back to the brain. So it's a two-way
conversation that's going on all the time. And we're used to the fact that the brain tells the body what to do. That's our common mode where we think of something and we do it. But if I sit here by way of a demonstration and I close my hand, nothing happens. But if I actually clench it into a fist, a real fist, I feel my heart rate going up. And I've done this on monitors, vital sign monitors, and I can see my blood pressure is going up, and I can see my respiration rates going up. Because what's happening is that right now my hand is telling my body, get ready, get ready, get ready. And it won't stop doing that until I release my hand and put it in my lap. And then it'll say, we're okay, we're okay. Mm-hmm. So that two-way conversation is going on, and that conversation in pathologic situations becomes stuck. And then the brain is amping the body is amping the brain. They can't get out of this terrible situation where they're extremely anxious, they're sleeping poorly, they're very irritable. Their anger goes from 1 out of 10 to 10 out of 10 over nothing big, nothing important. Could be a cup of coffee, and they just go off. And they're in a bad state of affairs because that sympathetic nervous system is stuck in the on position. And
so it's kind of a pathological loop, basically, that doesn't shut off. And I understand that there were even functional MRI studies done, so that measured, you mentioned the centers in the brain, like some of them are hippocampus, amygdala, right? So, and they actually measured that people that had this traumatic events, they have even change in the volume of those centers, and as well as the activation, right? So like more than normal brain activation that was shown on this
structural changes to the brain. Yeah.
So it's a real almost like organic change that might happen to the brain due to this abnormal vicious cycle, this loop.
Yeah, and what we do for that is this conversation comes together in the sympathetic chain going through the neck. And if we precisely inject a portion of long-acting local anesthetic around that nerve, we turn off that conversation and we kind of break the loop. The brain can't amp the body and the body can't amp the brain. And it's kind of like if you've ever seen a computer with the blue screen of death where it's just locked up. It's you can't do anything with it. You can't code through it. You can't. But if you reach down and unplug the computer and plug it back in, what we see then is that there was nothing wrong with the hardware or software. It was stuck in a loop it couldn't get itself out of. And that is the situation that we see people in. And by turning off that conversation selectively with the stellate ganglion block, or cervical sympathetic chain block, we turn that off. It gets to spin down to its baseline. And when it comes back on at its normal settings. And we see in 35 papers in the medical literature, and I've published 15 of them, at least, we see durable response to treatment. We see people getting better and staying better once we reset that system.
So it's just basically, as you gave an analogy with the computer, it's basically like a reset, and you're almost putting the system at rest for a period of time. So, and then it has a chance to reboot and function more properly.
Yeah, that's a nice way of putting it. Of course, we're not really like an electronic chip in there. There's much more than that. And nerves do much more than we think they do. They do, for instance, just regular nerves that, make your hand move or make your legs move. They don't just send electrical signals. They have some other trophic factors involved in them that's involved in keeping that part of the body healthy and well. there are portions of the vagus nerve that they actually feel are involved in physical transport, not just of signals, but of substance, which is entirely new. It's an entirely new concept that this isn't just electronic signals. So there is more to it than that, but that's a nice model to think about it, where it's just resetting something that's stuck. But we know that there's circulatory pattern changes in the brain that happen after a stellate ganglion block. We know that there's the responsiveness of the endothelium itself changes after a stellate ganglion block. There's so much going on that it's a challenge for us to appreciate how complex the system is. But we do know what happens when we do a block, and we do see that the effects that we're measuring, the clinically relevant outcomes, which is people are feeling better.
That's really remarkable, and I understand that this is not really a new treatment. So originally, this treatment has been used almost like 100 years ago for the specific pain syndromes in the upper extremity, like regional, pain syndrome and postherpetic neuralgia and some other things, right?
Yeah, Dr. Melinek, you're absolutely right. I mean, this has been around and in use for a long time. Easily, like Daniel Moore wrote the seminal textbook called The Stellate Ganglion in 1954, and he outlined all the conditions that it was, being used to treat, and it was a seminal work. So this has been, the technique of blocking this has been around a long time. Doing it with ultrasound made it more safe and more precise, and doing it for PTSD is a new application. Doing it for anxiety is a new application. We just published a paper, got accepted for publication last week, our paper on stellate ganglion block and traumatic brain injury symptoms. So
wow, really? Oh,
yeah,
congratulations. That is really interesting. I mean, of course, the PTSD and traumatic brain injury are a little bit different, but there is a little overlap, isn't it? So, in terms of the symptomatology and the symptoms people experience. So,
well, that's part of the problem. That's why that first it was a case series, which is a level 4 study, a lower level study, but it did show that when we looked at the main test that the Department of Defense and the Veteran Affairs uses to track TBI symptoms, we did see an improvement in, at 1 month, they were 50% improved. It sustained. So, but there is overlap between PTSD and TBI, and really being able to, we need to do a better job at teasing out, hey, what symptoms are we improving when we do this? Are they specifically, but what we see is that we are improving that. I mean, TBI is a whole nother topic. I'm happy to talk about that because it turns out it's a much bigger topic than we think. It just published in JAMA Network about 3 weeks ago. It was a survey of Veteran Affairs and Department of Defense data looking at almost 2 million, just under 2 million service members who had either penetrating traumatic brain injury, severe traumatic brain injury, moderate traumatic brain injury, or mild traumatic brain injury. And they looked at them and they said, hey, what's their risk of developing brain cancer? And so you bonk your head, you get knocked unconscious. If it's like a mild traumatic brain injury and it's graded as mild, it turns out they were not able to see any increased risk in brain cancer. But starting with moderate traumatic brain injury, severe traumatic brain injury, and definitely in penetrating traumatic brain injury, they saw this stepwise increase in risk of developing brain cancer. Now, that is an entirely new concept. That is something that no one has looked at. And it really puts the onus on the Department of Defense, where people are using things that go boom all day long, hey, how can we better take care of our service members that are artillerymen, that are tankers, that are, around, big naval guns, or, even rockets launching. I mean, these things are very loud, and that the explosion of those launches, like as a SEAL, I launched plenty of, they're called AT-4 anti-tank rounds. It's an explosion. You're holding that tube. It's an explosion that happens in that tube. And you would have headaches at the end of the day after shooting, 4 or 5 of those. And you just
concussion as a minimum. Yeah.
And it turns out that this is like you could probably ask an 8-year-old if it's bad for the brain. It turns out that's bad for the brain, being around lots of explosions. And now we're seeing this evidence. So I think that's going to be an area where we really need to start looking at this.
Wow.
What
Well,
can we do to mitigate that? Yeah.
Exactly. Yeah, you know, of course, started with this unique PTSD treatments, and now you're branching onto significantly, more serious, disorders. Sounds like. But going back to the anxiety, as you mentioned. Because you have also published last year the Stellate Ganglion Block article and you demonstrated that it reduces the anxiety symptoms by half, so 50%. And you did the case study that you guys published in June of 2023. That's quite remarkable, I have to say. So that the effect of the Stellate Ganglion Block is a 50% reduction in in the symptoms. And we know that anxiety disorders, affect close to 40% of US population, and it's growing, especially among adults under the age of 50, I understand. So, and so I'm just curious, again, the Stellate Ganglion Block itself, of course, it's a procedure, so it comes with the certain risks, but it is such a quick and seemingly very sleek procedure that can be done in a very safe, guided manner, right? So can you walk us through how is it done?
Sure. I mean, I do this, of course, multiple times a day. And just backing up, like, hey, how did I come to all this stuff? It was
Right.
I'm a clinician, right? I'm a full-time clinician. I am not a researcher. But my patients had these conditions, and so I was treating them. So when I see something, when I notice something, when I see a trend, then we do follow up on our patients. And then if we see a trend, then we ask an institutional review board for permission to look at our own data, to go back and retrospectively look at this and see trends. And that's exactly what happened with the anxiety, which the anxiety was something that we realized that the tests for post-traumatic stress disorder weren't capturing what all of our patients were feeling. So we added other specific tests for anxiety, specifically the Generalized Anxiety Disorder 7 scale, which is commonly used. And we saw, like, hey, these people just with anxiety, not with PTSD, are also getting better. And then we look back at years of data, and we were able to, and again, that when you look back at your own data from what you were doing without making a hypothesis at the beginning, it's a low level of medical evidence. It's a level 4 evidence, but it's still the start of seeing these trends. And then how do you do a stellate ganglion block? I've done about almost 3,800 of these. And
my
I've done
God.
them all without a single serious adverse event. We use a 25 gauge needle, which is a very thin needle, like an acupuncture sized needle. And what we'll do is, after I spend a lot of time just talking to people about what's going on, like just like we're talking now, like, hey, we're looking to reset this fight or flight nervous system. I go through all this with them. I do a detailed informed consent, and I'll tell you that the risks are extremely low, especially in my hands. And the risk of a skilled providers, they're very low. The risk of bleeding or infection is less than 1 in 10,000. The risk of accidentally injecting into a blood vessel is less than 1 in 1,000. Now, that study, that 1 in 1,000 number, that's from a German study of looking at 10,000 stellate ganglion blocks. And that was done before there was ultrasound. So that's before they could even see anything. They were done blindly, no fluoroscopic, no ultrasound guidance. It was still that safe.
Oh, wow. So they did it blindly, and they still didn't have as many.
And they put a needle.
Yeah.
Which is
and just
bold.
to so you mentioned that the intravascular uptake, so that can sometimes cause seizures. That's the main concern, right? So because
if
of the
you
medicine.
inject into some blood vessels that are going, particularly the vertebral artery or the carotid artery, which is very large, very easy to see. But if you were to inject into them, that even a wisp of that local anesthetic would go right to the brain, and it would cause a seizure within a half a milliliter. I mean, it would just cause a seizure like that. I
But
witnessed
that's
that once when somebody else was doing a block. I was in the room when that happened, and it was immediate.
yeah.
But if you take stage precautions at each step of the way, I'm an expert at this anatomy. I'm an expert at finding these blood vessels. I'm an expert in the use of Doppler ultrasound. And so when you
Because
find all
you
the blood
use
vessels,
yeah,
yeah,
because I mean, to mitigate the risks, you obviously use guidance. I
oh
mean,
yeah,
people use the
absolutely.
either fluoroscopic or live X-ray guidance or the ultrasonic guidance, obviously, where you can see the blood vessels right there, and you're just basically navigating your needle to the correct location,
Yeah, and
avoiding
I think
all
that
the
it's
vasculature.
basically been accepted that fluoroscopic guidance is absolutely inferior for doing stellate ganglion blocks in a comfortable fashion, because you're going after a nerve. A nerve is soft tissue. The only thing you can see with the fluoroscopic guidance is you can see the bones, and the bones don't. There's so much variation. You don't know where those blood vessels are running. I can tell you if people were looking at these blood vessels, they would be chilled to think where they're sticking the needle. But you can see the blood vessels, you can see the nerves, you can go around everything. It's much more comfortable and it's much safer. And you don't have to use contrast dye, which they use when they do fluoroscopic guidance. You don't have to take the precautions that can go with that or the allergies that can go with that. But also just psychologically, if you've ever been, a fluoroscope is a machine that's used to guide procedures with x-rays. So it's this big giant thing that swings up over your head, and they put drapes on you, and then they shoot x-ray beams through your neck, which aren't really that good for you at all. And because they can't see where the nerves are,
You can
they
only see bones, obviously, with that. Yeah.
it hurts more. So
Oh, I see.
it's just one of those things where it's more painful. I can do this, and this procedure is on a scale of 1 to 10. It's a 1 out of 10 for pain. It's very low pain.
That's interesting. Yeah.
So,
Wow. And I've watched you. Oh yeah, sure. Yeah. I watched you doing it. And
so let's go back to doing it. So what I do is, once I explain everything, once I do informed consent, and once I answer all their questions and they lay down on the table, I raise the table up, I explain everything I'm doing. So usually I have them keep their clothes on, their shirts on, and I just put a piece of tape to kind of tape things out of the way. I clean up the skin with a skin cleaner called Fluoroprep. I try to keep things very calm. Only nice music playing, low voice.
That's
Clean
nice.
up the
And
skin.
they're awake and they're not sedated, obviously.
They are awake and unsedated. There is no need to sedate someone on this procedure. I think in the thousands I've sedated 2 people. 2 people, they got some by mouth Valium before the procedure just because they were just in the grip. But otherwise, what happens, it's not just that I don't like sedating people. I have no problem with sedating people, but then they don't get to feel what's happening to them. And that aha moment is actually can make a big difference in their outcomes. So we clean out the skin, put some sterile ultrasound gel. I look, and first we do, in my clinic, we published the first papers that showed when you did 2-level blocks. So we block at the C6 level and the C4 level. We split the dose between those 2 levels. Right at the cervical sympathetic chain, I numb the skin with a buffered lidocaine so it doesn't sting. I slowly place a very thin needle right alongside the sympathetic chain. I slowly inject. They'll feel some pressure, which is normal. And I'm talking to them. I'm saying, hey, if you feel any funny taste in your mouth or ringing in your ears, any sign of potential intravascular uptake, they can just talk to me. And so everything goes slow. I take about 2 minutes to do the C6 level, just nice, slow push. Because I'm doing the pushing, I feel the resistance on the syringe that tells me I'm not in a blood vessel. I can see the spread of the anesthetic on the ultrasound, and I'm talking to the patient, and I'm looking at their carotid, which is telling me their pulse. I'm looking at their internal jugular vein, which actually every time you take a breath, it changes shape and size. So you have perfect monitoring. They're there, you're talking to them. It couldn't be better. And then I'm asking them, if they're not saying anything, I tell her, hey, you're going to get tired of me asking if you're okay, but if you're okay, and I tell them it's painless for them to talk while it's going on. They don't feel like they have a splinter in their neck. We do the first one, then we go up the second, the C4 level, which is close to the jaw. That one takes about 30 seconds. It's less stuff that I'm injecting, and we inject that, and then they lay flat. For everything comes out, I wipe off the ultrasound gel. If they need a Band-Aid, I put a Band-Aid on. I take it off before they even leave because it's just a tiny hole.
Wow.
After 5 minutes, and this is the important part, Dr. Melnick, is after 5 minutes, they sit up on the edge of the bed, and then both myself and my very skilled assistant will score how their eye looks. And what we need to see is we need to see that if we do the right stellate ganglion block, we need to see the right eyelid droop. We need to see the pupil get smaller on the right side, and we need to see the white part of the eye, the sclera, get pink or red. These are all outward signs that we actually blocked the cervical chain, that we blocked the sympathetic nervous system, that it was a well-done block. Because if we don't do a well-done block, then we don't know what happened. And what I saw
this is your confirmation that you basically did the
Yeah.
correct block, and it's called the Horner's. Yes, Horner's
syndrome. Yeah.
sign.
So when I look at them, I'm saying I'm doing their scoring, but I don't say anything out loud, so I don't influence the person that comes next. The person that comes next, they say each one of those topics out loud on a scale of 0. There's no difference between the two eyes. 1, yeah, I guess if I look closely, there is a difference. Or 2, an obvious difference. It's obviously drooping. It's obviously the pupil is much smaller. So, and we published that scoring scale in 2015 in one of the first clinical practice guidelines that we put on this, because I saw so many doctors in the hospital doing these and saying it's a good block. And I'd say,
but it's not.
The pupil is not smaller. No, it's a good block. Their eyelid's not drooping. No, it's a good block. And then other things that happen is they'll get congestion just in this nostril on the side that we block, temporary congestion in like the right nostril. Because when you're in fight or flight, your airways get as big as possible. When you block the fight or flight, those airways get small and congested, and that's temporary. All of these things that I just described with the eye last maybe 1 to 4 hours, and then that's it. Then they go back to normal.
Wow, that is so easy.
That's how we do it.
Seems easy, but it has to be done still by the, very well-trained physician, obviously. So
I have
under
to
the
tell
guidance,
you, Dr. Melnick, there are times when I'm looking at next and I'm like, how am I going to get a needle safely over to where I need to go? Because just so they have maybe a whole rat's nest of blood vessels right where I want to, put the needle in. You need to know these anatomic variants. You need to look for them. And it's still a challenge. You get very, high body mass index patients come in and you don't know where their neck and their shoulders end, but we can safely block them. But it takes a lot of experience and it takes a lot of skill.
Wow, and I can't believe that you did over 3,000 blocks. That's really impressive. So we're going to take a very quick break, and we'll come back to talk to remarkable Dr. Sean.
This podcast represents the personal views and opinions of the host and the guests and does not constitute medical advice. The statements contained in this podcast have not been evaluated by the FDA. Any products or treatments mentioned are not intended to diagnose, treat, or prevent any disease. And now your host, Dr. Irina.
The way you describe this procedure seems to be so easy, and I understand it might take as little as 15 minutes, especially in your hands and properly trained physician hands. But I'm curious, how fast do people feel any changes in their symptoms?
Well, that's a great question, because a lot of times if people go on YouTube and they look in the videos, they're always being shown like these dramatic cases where people are sobbing with relief while the needle is still in their neck. And we have patients that do that, but I think it sets up a unrealistic expectation. What we see is in most of the cases, people are feeling better within minutes. Usually amazing. Minutes to 20 minutes, they're feeling relaxed, they're feeling more calm. I usually will ask them as I'm consenting them, where do they feel their tension in their body? And you hear everything. Some people say, I feel my tension in my feet, or I feel it in my gut, or I feel it in my tight chest. Neck and shoulders is also very common. My jaw, I clench my jaw. So they'll tell you where they're keeping their tension. And I'm looking for some kind of, after the block, whether it's, 5 minutes, 20 minutes after, because I monitor all these people for a while. I look for some kind of calmness starting to happen, because we describe calmness as being kind of more in the brain, and in the body, something that was tense that's now relaxing. That's the initial sign that it looks like, okay, we see that they had a good Horner syndrome, a good block. We scored it. It scored at least a 4 out of 6 on our scoring plan, so we know we have a good block. And then they start to have these effects. Now, some people will feel that within minutes. I have had very reliable people who are friends of mine tell me that they didn't notice anything for a couple of days, for 2 days
Mhm.
after. And then they were in a situation that would have really made them anxious. And they were like, huh, I'm not anxious. So some
Interesting.
people, that uncoiling takes time. Sometimes they won't notice it, but their spouse will notice it, and they'll be like, "Oh my God, you're so different. Yeah, I can't even.
Oh,
You're not even the
wow.
same person." So some people
Interesting.
don't have good self-awareness.
Interesting. Yeah, that's very telling, of course. And Sean, how many treatments on average people really require for, let's say, moderately severe chronic anxiety or PTSD?
Boy, that's a great question, because the truth of the matter is we don't know. But this is how I do it. Uh, Even people with very severe symptoms can be done in one treatment. Now, when I say one treatment, what we're doing these days is they come in on day one, and we do a C6 and C4 block, so 2-level block on the right side. And then the next day we do a 2-level block on the left side. Because one of our papers that we published, we saw early on, even going back to 2015, we noticed that, hey, some people weren't responding. And I was dealing that time, I was dealing with only active duty military special operations. And so these were very reliable people that just wanted to get back to the fight. Like
Right.
they didn't have secondary gain issues. They weren't trying to get disability. They just wanted to get back and be better at their job. So it's a very nice population to study, because there wasn't anything, if they didn't feel well, they really didn't feel well.
They really
So
wanted to go back, yeah,
they really
in
just
the
wanted to go
field,
back.
basically.
Yeah. And
Yeah.
every now and then I would do a right side, because at that time we were only doing the right side. The initial papers were all on right-sided stellate ganglion blocks. And when we did that, we noticed some people didn't respond at all. And I was like, what is going on? And then one of the people that I had trained to do these, he called me up and said, hey, I just want to tell you something. Like I did the right side on this person with PTSD symptoms, and they didn't get better. And when they didn't get better, the next day I did the left side, and then they got better. And I said, I never trained you to do that. He's like, I know, but it worked. And so I knew who it didn't work on. I knew, because they were in my command. And I went and got them out of the gym, and I said, hey, we should do the left side on you. We did it, and then they felt better. And then we realized, okay, something's up here. At the end of the day, we're all wired a little bit differently.
Right.
And
It's just a
what we see-
personal anatomy, personal wiring that can.
And I spent a lot of energy trying to figure out at one point, should I block the left or should I block the right? And what I realized is I should block both, because what we see is most people, it's additive. And we learned this over the years. People would, in our clinic here in Annapolis, Maryland, the Stellate Institute, which is part of Regenerative Orthopedic Sports Medicine, we would have people, we've seen people from 48 states and 10 countries. So people would fly in to see us, and then we would do a right-sided stellate ganglion block. And since they flew in, we knew that they might need a left-side block if they didn't respond. If they were one of those, in our paper, we showed 1 in 20 people only respond on the left-hand side. And that was another study we published. So then we kept a spot for them so we could do the left side if we needed. If they didn't respond, we would do that. So
but you have to do it on a separate day, because you cannot do both on the same time. Otherwise, you can close their airways.
And
right?
it's a really important point. And I can see the timestamp on videos of people on YouTube doing the right side and then doing the left side, 45 minutes later or something. And it's actually the recurrent laryngeal nerve comes off of nerves right near where we're putting local anesthetic, and it can make the vocal cord temporarily paralyzed. Now, the way when I'm talking, my vocal cords are moving in and out right now and making sound. And if it became paralyzed, it could paralyze in the closed position. It could just flop in the closed position, which is no big deal. You have a hoarse voice for a few hours, and then it will not interfere with your ability to breathe or swallow. You're okay. But if that happened also on the other side, and that only happens about 15% of the time, and that's the published average on that. But if that happened on both sides at the same time, that could be real respiratory distress, which would be very anxiety provoking. The last thing I want to do for my patient is give them a traumatic episode where they're having shortness of breath and having to lean forward to gasp. So the way we do that is we do one on one side, let it completely clear, and they do the other on the next day. And that is because I want them to have a safe and good experience. And I think that is the only way that they really should be done physiologically, although you see people doing them bilaterally, and I think that it's I'm sure that they're having bad experiences that they're not reporting, but we don't do that. What the
You
heck
do
were we
it
talking about?
in a very safe manner, obviously. Wow, this is interesting. I mean, I didn't realize that it might just take one treatment
Oh
for
yeah.
some people and have such
So
a significant improvement in their life. That's really
Yeah. So
remarkable.
what we say is, what we've seen is about 1/3 of the patients that we treat are in this one and done category. They usually had some kind of distant trauma. They're still amped. They come in, we fix them, and then they go back. Some people will re-trigger at certain times. Maybe they're having to work near where their trigger is. Maybe their trigger is driving, because they had a horrible car accident. Maybe. So some people will re-trigger. Now, what I tell people is, no matter how bad their symptoms are, look, first thing we do, we treat you, and then we make sure you have a good block, and then we see how you're doing. We redo your questionnaires, your score questionnaires at 1 week. If you're better at a week, it probably had something to do with the block that we did, because some people just get better. So we want to do a close time period to see, hey, does this seem to be doing better? And then if they're doing better at a month, then we say, oh, they had a durable response to treatment. If they had a durable response to treatment, then we just say, okay, if symptoms come back, if your symptoms return, this can safely be repeated if it needs to. And we have to tell them, and if your symptoms come back, don't feel guilty. It's not something that you did. Because I added that because so many people feel guilty because they can't just get over their symptoms. And then if they go away, they feel guilty because they think they did something to make them back. It's the autonomic nervous system. We don't have conscious control of it. We don't need to swim upstream on the guilt as well. Let the guilt go. It's not your fault. It's not anything that you did. It's your autonomic nervous system just got looped again, and we're just going to reset it again if we need to. If we don't need to, great.
And in a certain way, it's your autonomic nervous system, as you said, trying to kind of protect you and prepare you for the, certain potential danger, and etc. So it just has that aberrant, nonstop looping, as you said, that you're disrupting in such an sleek and seemingly easy procedure. It basically sounds like almost when a dentist numbs your gums, so anesthetizing your pain nerve so that he or she can perform the dental procedure. So, and then of course it stays there for a couple of hours and then wears off. I could almost compare your procedure with that type of, easy numbing of the very unique, sympathetic ganglion chain.
Well, it's that would be a local numbing of a peripheral nerve, but it's similar. It's numbing it, but this is targeting that sympathetic chain, which is has a far-reaching whole body effects. So it's not just happening locally. When we're doing this, we're affecting the whole system, the whole mind and body, which is kind of exciting.
Yeah, that is. And I know that you actually talking about that you recently started studying more the vagus nerve block. So because of course the vagus nerve now gained huge popularity in health and wellness and trauma, from GI disorders to psychosomatic etc. disorders. And I was wondering what exactly are you currently doing for the vagus nerve, since it also has the outreach to the entire body, as we now understand?
Yeah, absolutely. It has a lot to do. They think that there may be some vagus nerve dysfunction going on, and even obesity, which I know obesity is a rare condition in this country, but still some people have that. But,
Not.
and also in inflammatory conditions. So really a lot of the rheumatologic conditions that people are on very heavy duty drugs for perhaps can be moderated through the, blocking the vagus nerve. Vagus nerve and vagus nerve blocks are in their infancy of research. And frankly, what I have is only anecdotal, low level expert opinion level evidence, and we have yet to do a study on it. We continue to do studies, we continue to publish papers. There's so much to do, but that is one of the things that I think will be a very interesting area. The thing is, the vagus nerve, when you go after the vagus nerve in the neck area, you're sub-millimeters away from the great vessels, from the carotid artery, from the internal jugular vein, and they're big, important vessels, and it really wouldn't take. You have to have an extremely skilled operator that goes after that. It's another level of skill, even beyond the precision you need to do stellate ganglion blocks well. Getting into that carotid sheath to block that vagus nerve is very challenging. But honestly, there are certain variants of the cervical sympathetic chain where the cervical sympathetic chain runs with the vagus nerve. And that's kind of how like horses and a lot of animals are. They have an autonomic trunk where both the sympathetic and parasympathetic run together. So in some humans, they have a variant that's similar to that. The difference is that those sympathetic nerves are jacking into, and all along the way, they're jacking and riding along with the other peripheral nerves, the other nerves throughout the body, and they ride all the way out into every aspect of the body. But the vagus is pretty much going along, the gut and GI tract, but it still has far-reaching ramifications and implications and treatment possibilities.
And where do you see, like, what type of disorders? I mean, so far I understand it's anecdotal, but where do you see a really good clinical application of the
IBS,
vagus nerve?
particularly IBS-C.
IBS, wow.
IBS-C,
irritable
IBS-D.
bowel syndrome.
Yeah, and so any kind of gut symptoms, it's usually worth a try. I have had mixed responses to, because it's the same kind of embryologic layer with skin. So sometimes I've seen people with skin lesions report, hey, my eczema cleared up. So I don't know. I'm not saying that it's a treatment for that. I am absolutely not saying that. I'm saying that there's these possibilities. When I was a kid, I remember being bummed out because the map was all covered in. Like there was no spots on the globe that were left to be discovered. And boy, was I wrong, because every day I go to work and there's nothing but terra incognita in front of me. There's nothing but and the things that we think we know are probably not accurate or probably not incorrect. But like really getting down with, hey, what does the vagus do? What is the manipulation of the vagus nerve? What treasure trove is available to us for really helping people, which anybody that's a physician, and we got into this business because we want to help you. And what can we do? And it's exciting. I've seen anecdotally, I had one case, it was a dramatic case. It was a person, retired law enforcement, very level, very accurate, very stable guy. And he was now working as a security contractor, and he developed the hiccups. Sounds pretty innocent. And the hiccups didn't go away. And then he had the hiccups so bad that he'd hiccup until he vomited. And then after he vomited, the hiccups would go away for a little while. Well, after a week, the hiccups didn't go away even when he vomited. And then nothing happened. And then over the course of the next 13 months, he had his whole body MRI'd. He had consults with multiple subspecialties, including neurology, including general surgery, including pulmonology, including gastroenterologists. Nobody had an idea what was going on with him. They couldn't find any anatomic reason for him to have this horrible hiccuping.
Yeah,
and
it's
it made
very
it so he
disturbing and
couldn't do his
destructive
job.
to your life.
He couldn't do his job. He lost 35 pounds, and he wasn't a big guy before. He lost 35 pounds, and he was losing his will to eat at this point. He would be awake for up to 4 days in a row from hiccuping. I mean, you'd think it's just
innocent
hiccups, but it was
little
actually purgatory for him,
nuisance,
or worse.
Wow.
And then he came to me and he's like, look, I don't know what to do. He was a guy at the edge of his rope. And I'm like, look, if you want, we can try blocking your vagus nerves. And he's like, just do it. He goes, what do I have to lose? And I said, and I don't do things just because people are desperate. I did them because I thought, hey, this is an angle no one's looked. He failed every drug therapy. He failed every other kind of therapy. They were even using antipsychotics on him, which sometimes you use. Thorazine is the last resort medicine for hiccups, which is a high-risk medication. So he'd done everything. No, they couldn't find anything wrong with him. Nobody even suggested anything. So we did vagus nerve blocks. I did the right side, and his hiccups stopped for the first time in 13 years. And then I followed him for I told him to come back to the clinic in 4 days and let me know how things were going. And every now and then his hiccups would come back, but they would still go away. So I said, look, we should do the left side. So we blocked his left vagus nerve, and his hiccups completely went away, and they've stayed away since then. What did I do?
Oh my God.
Dr. Melnick, I don't know what I
Impressive.
did. And I can't accurately say what I did. What I do know is that this person, so I might not academically know the answer, but this person feels like they have their life back.
Oh my
And they're
God.
getting their
That
job
is,
back,
yeah.
and they're eating again, and they're sleeping again. And
It's
so I don't,
impressive.
yeah,
It's like a life-saving type of procedure in the quality of life, So, and
but
I mean,
I want to be clear though. I'm not offering it as a treatment for everything that we don't know what's going on. I'm saying that there are times when either it's control of inflammation throughout the body, it's control of the gut. These may be areas that we need to do more research on, real research, and figure out, hey, is this helping? But it's challenging research to do. You have to have the right patient population, and you have to have someone with the right skills to do this.
Well, I mean, as you mentioned, yes, you don't know yet, the whole, pattern mechanism perhaps, and there is so much to explore, so I love your analogy with the map, so we are medical doctors, could be detectives and explorers, right? So, but the medical field itself, has been empirical since, the dawn of time. So we actually see, certain empirical observations, and then sometimes years or even centuries later, we understand the actual mechanism, so, and we can break it down and reproduce and etc. So I think, it's really honorable that you're willing to try to help a person, especially if the, risk-benefit ratio is actually in the patient's favor, so, and you're definitely changing people's lives, so one person, one soldier at a time. So I'm really, really thankful, Sean, for coming today and for enlightening us on this unique treatment and your service to, humanity and especially our U.S. military force.
It was all my pleasure, Irina, and thank you so much for asking me to come on and talk and share this information. A lot of people still say, I never heard of this. I never heard of that as a treatment. And every time that we get it out, who knows where if you help one person and you turn their life around, who knows what those ripples will be, for their family, for their people they work with. It's a big deal. It really is helping people. And so the chance to share that is fantastic. But it's not the stuff with stellate ganglion block. We have good, excellent research, including level 1 study, where we did a fake sham block versus a real SGB. A sham block was done with saline in a different part of the neck, and then we did a real stellate ganglion block. And we did that in Germany, in Fort Bragg, and out in Hawaii, another Army hospital in Hawaii. And so that's called a multi-center randomized control trial. And it took us...
Which is the highest standard of the research,
obviously. It took us years to put that together. And it's the level 1 study. It's the highest level of medical evidence that we have. Right. And we showed beyond a shadow of a doubt, beyond any kind of statistical significance, that we had the people that got the stellate ganglion block had good, durable response. And we were using the gold standard measurements for post-traumatic stress disorder at the time. So we have high level evidence showing that this is working. A lot of these new thrusts started with lower level evidence, but the goal is to work towards more and more higher level evidence. And but that's the goal.
Yeah, no, that is really remarkable. And it can also be used as an really invaluable adjunct to like trauma-focused psychotherapy, or other type of course, treatments for this.
With Ohio State, we have a current randomized clinical trial where the two groups are, one group gets trauma-focused therapy and one group gets trauma-focused therapy plus stellate ganglion block. That's an ongoing, we're directly involved in that study. Navy SEAL Foundation actually provided a lot of the monetary support for that. So that's an ongoing thing because we really want to know, hey, it seems intuitive that things would work better in combination, but we want to know what's the real answer there. And what I suspect is that the combination. Now, I think that may be even the working hypothesis, but I guess we'll see if it does.
That's remarkable.
As soon as we have it, we'll publish it. We're still in data collection on that one. But you're right. I think that I feel, and this is where I'm past my research, but I think that having someone that cares about that person and is a professional at plumbing these issues of anxiety and PTSD, behavioral health specialist is someone that's going to augment the therapy. I don't think they necessarily have to go right at the trauma all the time, but I don't mean to tell people how to do their job. As a physician, when I have to take tests, I study and I lay down neural pathways to that information to make it readily accessible. I don't know. It's not intuitive to me that going after bad stuff and really drilling down into bad memories is you're making strong neural pathways to those bad memories. And maybe it's better to let those demons stay quiet and put them on the shelf and let them get dusty.
Well, I respect your opinion, because you've been yourself on that battlefield, so you speak from your own experience. And I have to thank you for doing all this research, continue, really improving this field, so
myself, my colleague, Dr.
solutions.
Jim Lynch, have published most of those studies together. I work here with him now at the Stellate Institute as part of Regenerative Orthopedic Sports Medicine in Annapolis. And it's great having a colleague he was, again, in the military as long as I was as a physician. And we're clinical doctors. We are not researchers. But when we see things, we will sigh and collect the data. And it takes a lot of effort to put these papers out. But if it can, that is a chance for it to have an augmented effect.
And I hope you guys have some help, because you definitely are busy doctors, so helping people, but you do need a lot of help, and hopefully you will.
So are you. I mean, you're a busy doctor too, and here you are doing a podcast. So.
Yeah. And if anybody, like one of our listeners or some of our listeners rather, would want to find you, so what's the best way to connect?
A good way is our website, which is the Stellate Institute, all one word, thestellateinstitute.com. That'll get us to our site, which is packed with even the primary references. Other physicians use it to get references on Stellate and frequently asked questions. We do have some testimonials, which I think are helpful to people who are kind of making up their mind, and more information about all that. Or they can call our clinic here at 410-505-0530, and you'll get Kim or Hamish or lots of the phone.
One more time, the phone number would be
410-505-0530. And you get some really nice ladies, either Kim or Heather. They're wonderful.
Yeah, well, thank you so much. So I really feel privileged and honored having you, on our show. And thank you for explaining this amazing treatments to us.
Thank you, Dr. Melnick, very much. I'm humbled.
And thank you for joining us at Cures, Remedies, and Beyond, exploring science and the wisdom of health and healing. We hope to see you next time.